Thank you so much. It is an honor to be here with you all today. I think that international exchanges of information, comparing of experiences, and learning from each other is absolutely invaluable. As we have been working on the U.S. national strategy, we've had a number of consultations with other countries to see what we could learn from them as we moved forward. Had numerous discussions last year in Piran, Slovenia, at the meeting of the International Association for Suicide Prevention. We've had phone consultations with the Australian Suicide Prevention Office, and I'm so glad to be on this panel with Alan, and as well as with the Irish National Suicide Prevention Office. In part because the U.S. has recently launched the third version, our third U.S. national strategy for suicide prevention. And so we wanted to learn from other nations who have gone through several iterations of a national strategy, what they've learned as they moved forward. And there's the timing. Oh, I see it's right in front of me. That's very interesting. Okay. There we go. Actually, that's interesting because, is that yours, Alan? Okay. Let's see if we can go. There we go. Okay. So, we were really honored to have the new U.S. national strategy released at the White House just about 2 months ago. And you may notice Shelby Rowe sitting there, who is because part of the event was a panel with people with lived experience that was moderated by, you can just see him in the corner there, the U.S. Surgeon General, Vivek Murthy. It was a wonderful event and a wonderful start. Now you may wonder, well, how did the U.S. national strategy occur, this version? Well, you might think that bureaucrats like me might have surfaced it and pushed it up. That was actually not what happened. It was a request of the White House that we revise the national strategy. And so there was a lot of influence behind it, but also some pressure. Because we really needed to have it come out this spring. Now, as I said, this is the third version of the U.S. national strategy. So the first version came out in 2001. One thing that was interesting, there were some very good things in that national strategy. One was one objective was the creation of a suicide prevention resource center, which happened the next year in 2002, and Shelby is currently the director of the Suicide Prevention Resource Center. There was also a recommendation, one of the objectives was for a National Action Alliance for Suicide Prevention, a public-private partnership to oversee implementation of the national strategy. And there was a question yesterday about engaging the private sector, and I think that the National Action Alliance has had exactly that as one of their primary drivers. Okay. But one of the downsides of the 2001 national strategy was that there was nothing about clinical care that was in the national strategy. So that was a significant omission. After the National Action Alliance started, a task force was convened, co-chaired by Michael Hogan and David Covington, called the Clinical Care Task Force. And we heard from the Henry Ford Healthcare Center, from some of the work going on in the Veterans Administration. And so the 2012 strategy, that group made recommendations so that the 2012 strategy was much stronger in that regard. And that strength has been continued there. And these are just some more pictures of the White House event. I have no idea how to make slides like this. I lifted them from Brandon Johnson, Brandon succeeded me as suicide prevention branch when I moved to the 988 office and spent just a tremendous number of hours working on the national strategy. So that's Brandon there in that center picture, and that's the group of us who oversaw the development of the just released strategy. So let me give you an overview of the way this strategy is structured. So the key is that there are 4 strategic directions to make a comprehensive strategy. Strategic direction 1 was focused on community-based suicide prevention as being key. It has to happen at the local level. Now, in the US, every state has a suicide prevention coordinator, which is great. They vary in terms of how many resources they have at their disposal, how big the office is, et cetera. But every state suicide prevention coordinator that I've spoken to has always wrestled with, how do you get it to the local community level, right? How do you have sufficient resources to enable community-based suicide prevention to take place? So strategic direction 1 really focuses on that, including a real focus on building the infrastructure for community suicide prevention, right? The strategic direction 2, which was the one that I oversaw the development of, is on treatment and crisis services. And I'll go back to that. Strategic direction 3, surveillance, quality improvement and research. And NIMH was a major contributor to this. And we have great representation of NIMH at this meeting, which is wonderful. And strategic direction 4 was on health equity in suicide prevention, really looking at making sure that those who had not necessarily been reached by suicide prevention efforts previously were there. And that has included groups ranging from LGBTQI youth to rural areas to young Black kids who have had an escalating suicide rate in the United States. So this is the basic structure of with these 4 strategic directions. And I'll go into a little bit more about strategic direction 2. And so you can see one of those is goal 8, which is to implement effective suicide prevention services as a core component of healthcare. So that is, and this was really built on the tremendous work that was in the 2012 strategy that was part of that clinical care task force from the Action Alliance that I spoke of. And the goal 9 was to improve the quality and accessibility of crisis care services across all community. At the time that the 2012 strategy was released, we had no idea there would be a 988 in the United States. So 988 has been incorporated into the new strategy, as well as our goal to make 988 a catalyst for transforming behavioral health crisis services across America. So it's an ambitious goal, but it's embedded into the national strategy. So this is just to give you an idea of some of the things that are part of Goal 8, and you can see how it reflects the concepts and objectives of the Zero Suicide Initiative. I won't read all of them to you, but you can see some of the key words: identify, engage, treat, follow up, and making it standard care in public and private healthcare delivery. Objective 8.2, we talked yesterday a bit about the idea of there being protocols, right, that this is something that happens within Zero Suicide. It also happens within the Veterans Administration, that when someone's at heightened risk, there should be a defined way forward for meeting their healthcare needs that's different, and that doesn't vary from clinician to clinician. Obviously, some things will vary, but that the basics, such as doing a safety plan, would be present and would be part of protocols in that healthcare organization. And then Objective 8.3, and this is something that I've leaned heavily on Brian on because of the work that he's been doing at Henry Ford and some of the research that's been going on is really about implementing effective suicide prevention in emergency departments. And of course, the emergency department is the place where it's kind of the last stop from the crisis system and the entry point to the broader health system. And so sometimes folks will say, well, don't we want to avoid people going to emergency rooms? And we say, yes, absolutely. But once they get there, we want to make sure they get the best care possible. And the science is really strong. And so I actually co-chair a group that's looking at how to embed evidence-based suicide prevention in community departments across the U.S. Obviously a challenge, but a really important one. Here are some of the other objectives. And again, I won't read them to you, but you can, the entire U.S. national strategy, of course, is online for you to review. There's one that really focuses on lethal means. We have a whole goal on lethal means, but lethal means within the clinical context. We didn't really pay a lot of attention in the 2012 strategy to substance use issues, so that's an objective that we have included because we know that substance use disorders are second only to mood disorders in their association with suicide. Said that improving the quality and accessibility of crisis services was the other part of the strategic direction. And there, again, our goal is to really transform the fragmentation that too often is part of crisis services in the U.S. But the idea being that there needs to be connection between the call centers. We have over 200 call centers in the United States, at least one in every state, that is now answering 988, and that we want them to be able to either dispatch or rapidly connect with mobile crisis services, to have access to community crisis stabilization units, to be able to get into care quickly. Because the view is that it should be unacceptable in the United States of America for somebody with suicidal thoughts to have to wait a couple of months to get into mental health care. So we've been working on linking with what are called certified community behavioral health clinics, which have been another major initiative of my agency, SAMHSA. Now, one of the things that was really unique for this version of our national strategy, and Brian alluded to it yesterday, was that for the first time, it was accompanied by a federal action plan. So after the first national strategy in 2001, the hope was a National Action Alliance would move things forward, but we didn't end up having a National Action Alliance until 2010. Then with the second iteration, we didn't give necessarily a lot of thought to how we would help the Action Alliance move the agenda forward. But what this also idea came from the White House. It wasn't me figuring like this would be a really good idea. The White House asked for a federal action plan for every agency to contribute at least 3 things that they would do to move the U.S. national strategy forward. So the federal action plan includes over 200 actions that agencies and departments within the U.S. government have committed to doing to move the national strategy forward. And so these are just a couple of samples. Obviously, I'm not going to try to read to you all 200 action plans. If you are so inclined, they are all online. But for example, Indian Health Service is an agency within the U.S. Department of Health and Human Services, and they have pledged to implement evidence-based universal suicide risk screening across healthcare systems at all IHS areas and facilities. So the Indian Health Service runs a number of healthcare facilities within the United States. They have pledged to do this. SAMHSA has pledged to identify and disseminate prevention strategies to local communities on risk factors and social determinants of health related to suicide prevention based on community needs. That's from Goal 2. The U.S. Department of Agriculture pledged to identify strategies to support mobile crisis teams through existing rural development programs. And here are a couple of others from SAMHSA that we were engaged on, that we would improve data collection and reporting on critical 988 data, including suicide attempts in progress and both voluntary and involuntary emergency interventions, and to evaluate outcomes to support ongoing quality improvement. So that was a pledge that we made as part of our 988 office. Also related to 988, that in coordination with, and I don't expect you to know the acronyms, Department of Transportation, Office of Emergency Medical Services, they're the group who helps to provide some oversight for 911 in the U.S., that we would develop guidance on when a behavioral health crisis requires 911 engagement versus 988, because we're trying to move as much as we can from 911 to 988 in order to minimize unnecessary police involvement. But a lot of times you do need 911. The most obvious example is a suicide attempt in progress. We want to get an ambulance there as quickly as possible. That these additional items were that there are protocols for review of 988, 911 interactions on the local level, and to increase the number of 911 diversion programs that exist. And then the final one there is from the Department of Justice through their Mental Health Collaborative Program to provide grant funding for a number of different purposes. So again, this is just a sampling of the over 200 items that federal agencies and federal departments have committed to move the U.S. national strategy. It's certainly been a privilege to have worked both on the 2012 strategy as well as the current strategy. One of the things that we're really focusing on now is how do we monitor and evaluate implementation so that it's not just a strategy on the shelf. One part of it will be monitoring with federal agencies this action plan, but we're also working with the National Action Alliance about how to help support and monitor the private sector in moving forward, because this is not just a federal government strategy. It's a strategy for all of the United States, public and private sectors, both. And those are just a couple more examples. I'm not going to read all of them to you. So the next step is really around monitoring and evaluation. And that's one of the reasons, again, that the international conversations are so important, so that we can all learn from each other. And I think that that is it. Thank you.